Usually for Viva sessions, you will be shown 1 or 2 ECGs and asked to interpret. More than the Viva sessions, why I take this session is, you will be, during your perioperative period, you will be witnessing various ECG changes, which you have to manage. For that, you should know how to analyze the ECG, how to interpret it, and how to manage it. For that, I am taking this session. So for that, first, you all know these basics. Conduction system, it is the pacemaker is the SA node, then comes the AV node, bundle of His and the Purkinje fibers. So the impulse starts from the SA node, then it spread to the both atria. So both atria contract simultaneously. Then the impulse reaches the AV node, and there is a AV nodal delay. So first, when the atria contracts, correspondingly the electrical activity will be the P wave. And for the AV nodal delay, that is depicted as the PR interval. Then the impulse passes through the bundle of His right and left, and both the ventricles are contracted. That forms the QRS complex. Then the relaxation phase, it is the T wave. So that is a normal ECG waves. And the leads are, there are 6 limb leads and 6 chest leads. And the position of chest leads are often asked in the exam, that you should know. So you may be knowing it is the V1 on the right side of the sternum, 4th intercostal space, V2 on the left side, 4th space, V3 between V2 and V4, V4 5th space at the mid-clavicular line, V5 in the same space in the anterior axillary line, and V6 in the mid-axillary line. And something about the paper, you know, the papers run at the speed of 25 millimeter per second, so that you will be knowing what is a small square and what is a large square. So in the horizontally, in the ECG paper, it is the time. So for one small box, it is 0.04 seconds, and large box is 0.2 seconds. And vertically, it notes the voltage. That means one small box will be 1 millivolt. This helps in calculating the each waves, how much is the width and the height. And another important point is the standardization. This is often shown at the beginning of or at the end of the ECG paper. It usually is a square wave pattern of 1 milliwatt. Sorry. So this is also important. It has to be 2 large squares. If the standardization is less, that means all the waves will be of lesser amplitude. If it is more, all the waves will be of higher amplitude. So you have to make sure that the standardization is also correct before interpreting an ECG. And another is the overdamping and underdamping. This also is often asked in the examination. That means how this happens is the writing stylus of this ECG machine, if it is pressing too much on the paper, that causes overdamping, or the voltage of the wave will be decreased. In underdamping, this stylus of the machine is not pressed or correctly. That means there is spuriously increased amplitude you will get. So this has to be remembered, overdamping and underdamping. So comes to the normal ECG waves, you get P, QRST and the intervals, interval and PR segments, QT and ST. First we will see each wave. P wave normally is of 120 milliseconds, less than 120 milliseconds, and a height of 2.5 millimeters. You get abnormalities of P wave in atrial enlargement, right or left atrial enlargement. This will come across in the other ECGs. When I show, you will see this. In a right atrial enlargement, you get tall and peak T wave, which is called as P pulmonale. Whereas in the left atrial enlargement, you get a broad and nosed P wave. It's also called as P mitral. Whereas in a combined atrial enlargement, right and left atrial enlargement, the second peak and both peaks will be of almost equal. Whereas in the left atrial, the second peak will be higher. So in combined also is a broad and notch, but the peaks are equal. And the PR interval is another important. It denotes the AV nodal delay from the beginning of P to the beginning of QRS. Normal duration you have to know. And the various condition causes the prolongation and the shortening. It is shortened mainly in the WPW syndrome. PR segment is little different. Some examiners might ask, it is from the end of P to beginning of QRS. Another is the QRS. Usually the Q will be of small or not visible. But when you say it is a pathological Q wave, that is more important. When the Q wave is more than 25% of the succeeding R wave, or the width of the Q is more than 1 millimeter, it is called as pathological Q wave. Okay. And if it is associated with STT changes, it shows ischemia. And there is no STT changes means it is an old infarct. That these things you will be knowing, all these basics. And the QRS complex morphology is different depending upon the leads. The normal width is 0.08 to 0.12 seconds. And you get wide QRS in bundle branch blocks or ventricular premature contraction, or also in ventricular tachycardia. And the normal R wave progression in the chest leads, you have to understand how the R wave is progressed from V1 to V1 to V6. Why this QRS is very different in the chest leads is, as the impulse passes through the bundle of His, it passes to the left side and the right side. And because the left ventricle has a thicker muscle mass, that impulse will be more. So during V1, the higher amplitude is going away from the electrode. That means it causes a negative deflection. Whereas in the V6, since the activity is going towards the lead and the left ventricle is a thicker wall, that shows a positive deflection. That is a difference in the QRS complex in the chest leads. Another is QT interval. It is from the beginning of QRS to the end of T wave, and it actually inversely proportional to the heart rate. More than the normal QT, what is usually asked in the exam is what is corrected QT. It's also called as QTC. It is calculated by the formula, Besset's formula. That is, corrected QT equals the QT interval in the ECG divided by square root of the RR interval. Actually, it estimates the QT interval for a heart rate of 60. Because this QT interval will be in a patient with a bradycardia, you can understand. In a patient with a bradycardia, the QT will be spuriously widened. And in patient with a tachycardia, QT will be shortened. So you have to correct the QT interval for the normal heart rate. That is what is doing in a QTC. And this corrected QT detects patients at risk of ventricular arrhythmia, because a prolonged QT interval means that is the patient is at risk of ventricular arrhythmia. So all the intervals and then the wave morphology you have to understand, read. Another is the axis, though it's not very important. The normal axis is from -30 to 110. And the axis deviation easily you can identify by looking at the lead 1 and AVF alone. If both are positive, it is normal axis. If lead 1 is positive but AVF is negative, it is a possible left axis deviation. Whereas if 1 is negative and AVF is positive, it is right axis deviation. And if both are negative, it denotes extreme axis deviation. And then another is, how do you calculate the heart rate? That everyone will be knowing. I just refresh your memory. That is 300 divided by number of large squares, or 1500 divided by number of small squares between the RR. Now I will ask, this is applicable when the heart rate is regular. What will you do when a rhythm is abnormal? What will you do? This team. Can you answer? Which college are you from? I forgot. Amala. Okay, I remember you calling me. Okay, Shin. Yeah, I remember. Suppose the heart rate is irregular. Rhythm is irregular. How do you calculate the heart rate then? RR interval for? I will help you. If the rhythm is irregular, you look at the rhythm strip, there will be 6 seconds marks. Okay, so between the 3 seconds mark will be there. So between the 3 seconds, calculate how many QRS complex and multiply by 10. That will give the heart rate for 1 minute. Okay. So the usual abnormal ECGs cut for exams include arrhythmias, both tachy and bradyarrhythmias, ventricular hypertrophies, ischemias, electrolyte abnormalities, and so on. And the common causes of intraoperative arrhythmias include, all will be knowing. One common cause is light plane of anesthesia. Other causes include hypoxia or hypo or hypercarbia, and in patients with a structural heart disease, pre-existing heart disease, any electrolyte abnormality, and sometimes it could be a medication error, and it could be due to endocrine causes. So you should know which, you should rule out which is the cause of your electrolyte, ECG abnormality, and treat accordingly. So how do you interpret a normal ECG? Always the ECG, it will shows the name and the date and time of the recording. Look at the standardization if it is correct, otherwise the interpretation of the waves morphology will be difficult. Then look at the rhythm and calculate the rate, and see axis if you know, and look at the morphology of each waves, whether P waves are present throughout, each P is followed by QRS and not. And look at the segments intervals, if the normal or it is widened, and if there is any specific changes like ST segment depression or elevation or depression, anything like that. So always go in a sequential manner so that you won't miss anything. Okay. Before calculating the heart rate, you look at the rhythm, whether it is regular or irregular, and look at each wave morphology, whether P wave is present for all and each P is followed by QRS, or is there any missing beat, how the intervals, is there widened waves, or is the intervals are prolonged or shortened, and any specific change. If you go in a systematic way, you will not miss anything. And finally, after explaining the changes only, you say the diagnosis. For the exam also, before jumping to the diagnosis, first read the ECG. Okay. First interpret what are the changes you are seeing in the ECG, then you say your probable diagnosis. Then the examiner will ask you what could be the cause, or how you will manage, or what is your way. That is how usually the questions asked in the examination. And for perioperative monitoring, we usually use either a 3-lead or a 5-lead ECG. And in this, you can see place the chest lead and select accordingly which lead you want. Suppose in an ischemic patient, if the patient is already having an ischemic heart disease, you can select the leads accordingly. So now I will show you some possible ECGs kept for the examination, and you can take turns to answer. So I have, my postgraduate has compiled ECGs of arrhythmias, ectopics, bundle branch blocks, pacemaker ECG, hypertrophies, ischemic heart disease, and changes in some electrolyte abnormalities. So first we will discuss about the ECGs of arrhythmia. So arrhythmias could be tachyarrhythmias or bradyarrhythmias. In tachyarrhythmias, commonly it could be sinus tachycardia, atrial fibrillation or flutter, supraventricular tachycardia, ventricular tachycardia, and ventricular fibrillation. In bradyarrhythmias, it could be sinus brady, AV nodal blocks, junctional rhythm or idioventricular rhythm. These are the common arrhythmias kept for the exam. So first we will see what are the tachyarrhythmias. So anyone? Yourself. Don't think I have kept it in an order. You can interpret the ECG.
It's a sinus rhythm because the QRS complex is followed by a P wave.
Yes.
The RR intervals are equal. And there is narrow QRS complex, normal QRS complexes.
Okay. You said there are P waves, QRS, each P is followed by QRS. And how much is the rate? Approximate. Do you want to help? Next team can anybody?
The rate is about it is 300 divided by number of large boxes between the RR intervals.
Yes.
So it is about more than 100.
Okay.
So it is diagnosis may be a sinus tachycardia.
Okay. So it is a sinus tachycardia because there are P waves followed by QRS in each, but the rate is more. So what could be the cause? Suppose you see this in your intraoperative period in the monitor. What are the causes?
Sinus tachycardia during intraoperative period, we have to rule out any sympathetic stimulation due to any lighter plane of anesthesia, pain for the patient,
Yes,
any
very good.
hypotension.
Yes.
Then also there can be other causes
Yeah.
such as physiological,
Yeah.
then hyperthyroidism,
Yes.
hypoxia, hypocapnia.
Divya, you want to help?
Good evening, ma'am. Good evening, everyone. Sinus tachycardia is seen in physiological conditions like pain, anxiety, pregnancy, and metabolic causes are anemia, fever, hyperthyroidism, and it is also seen in cardiac conditions like hypotension, stenotic and ischemic diseases of the heart, pulmonary diseases such as COPD, asthma, and certain drugs also cause sinus tachycardia.
Okay. So as they said, during the intraoperative period, you should always rule out lighter plane of anesthesia or the patient is having any pain. Okay. So those things should come first, and hypovolemia and hypotension also. So you have to rule out the cause and treat accordingly. So next team, can you? So management is according to the cause.
This is showing a 12 lead ECG.
Yeah.
There is no P wave. And there's irregularly irregular rhythm.
Okay.
This may be an ECG of AF, atrial fibrillation.
Okay. So it is a 12 lead ECG. How much is the approximate heart rate? Can you?
Approximately rate is about 150.
So it is a rhythm is irregular. So what could be the cause? I mean, what is the rhythm?
Atrial fibrillation can be due to conditions like mitral stenosis.
So it's a, as you said, it is a ECG of atrial fibrillation. So what could be the causes?
Can be seen in mitral stenosis, hyperthyroidism, hypertension, and conditions like lone AF, holiday heart syndrome, hyperthyroidism.
Okay. So you can explain how the ECG in atrial fibrillation.
In atrial fibrillation, first I will confirm the identity of the patient and date and time of the ECG taken. ECG will show when verify the standardization of the ECG. The heart rate will be irregularly irregular, ranging from 100 to 150 beats per minute. Normal P waves will be absent. Instead, we can see fibrillatory waves due to small, rapid, irregular deflections, and normal narrow QRS complexes will be seen. These are the features of atrial fibrillation.
Okay. So you said the causes mitral stenosis and hyperthyroidism. So suppose this occurs in a patient with a mitral stenosis. Why are you worried about atrial fibrillation? Do you want to treat it? Are you worried about AF in a mitral stenosis?
Because in mitral stenosis, the passive filling phase is affected. So the ventricular filling depends on the atrial kick.
Yeah.
So in atrial fibrillation, that is affected. So the filling and cardiac output will be much more worsened.
Okay, very good. So in mitral stenosis, because the atrial kick will be absent because the rhythm is atrial fibrillation, ventricular filling will be affected. Another cause you said is old age. What happens in old age with AF? Are you worried about, or is it just a normal phenomena? You want to try? You are alone.
With old age, there will be distortion of conduction pathway, and it can be present normally in old ages, that like in chronic AF.
Yeah.
So duration of starting of AF is the must thing to be noted in such cases. If it's less than 48 hours, we should be starting anticoagulant or something.
No, why are you worried about AF in old age? Just like in MS, she said the ventricular filling will be affected.
Yeah.
Is there anything like that in old age? You want to add? Yes, there will be ventricular dysfunction in old age, ventricular dysfunction. So again, ventricular filling is affected. So how do you manage atrial fibrillation? Not in old age. I mean, suppose it is an MS case.
Beta blockers are the mainstay. Beta blockers are there, calcium channel blockers are there, and then amiodarone can be also used as a treatment. Then if the patient is not cardiac stable, synchronized cardioversion.
Synchronized cardioversion, how much?
150. Start with 100 joule, then increment 150.
Okay. Jisha, can you say it in so that it will be helpful for all? So management of atrial fibrillation.
If the patient is stable, we can do medical management with calcium channel blockers, beta blockers, or amiodarone. If the patient is hemodynamically unstable, we can do synchronized cardioversion with biphasic 120 to 200 joule. And if the patient is of chronic AF with high risk of embolic events, we have to start anticoagulation therapy. This is the management.
Okay, that is always in arrhythmia, ECGs with arrhythmia, you look whether the patient is stable or not. Hemodynamically unstable means you have to go for cardioversion, electrical therapy. Only in stable, go for pharmacological therapy. In atrial fibrillation, again the pharmacological therapy is rate control and rhythm control. In rate control, beta blockers and calcium channel blockers. Rhythm control comes the amiodarone. So you said you will start anticoagulation if it is in a chronic AF. How do you assess what you will see before starting anticoagulation?
Presence of a clot in the left
Yeah, how do you do that?
Echo.
You said anticoagulants has to be started. So before starting anticoagulation, how do you assess the need for anticoagulation?
Using a transthoracic echo, we can screen the left atrial clot.
Okay, you can simply do. Jisha or Divya?
Chart-SWA score can be used.
You heard of chart-SWA score. So what is chart-SWA score?
C stands for congestive.
This will be asked in the exam usually.
Yeah. C for congestive heart disease.
Yeah.
H for hypertension.
Hypertension.
A for age more than 65.
They will explain.
C for congestive heart failure, H for hypertension, A for age more than or equal to 75 years, D for diabetes mellitus, S for stroke or transient ischemic attacks, and V for vascular disease, A for age 65 to 75 years, and S for sex, more common in females.
Okay, initially it was only charts. VAS has added recently. Okay, so before starting anticoagulants, you look for the chart score. If the score is more than or equals 3, you need to start anticoagulants. Okay. So chart-SWA score. Each has given an appropriate score. And if it is more than or equals 3, you need to start anticoagulants. Okay. Who want to try the ECG? Try. see whether the P, QRS, T, everything is present, rhythm is regular or not. Definitely there is tachycardia, means heart rate is more. Okay. What about P wave? Yes. Is it?
Delta wave is present, so no.
Delta wave is, there is no delta wave.
Seems like so.
For the delta wave, there should be the slurring of the upstroke of the R wave. There is nothing like that. It is actually a flutter ECG. Can you explain it?
This ECG shows a rate of 150 beats per minute, regular RR interval, and in leads 2, 3 and AVF, we can see regular closely spaced inverted P waves giving a sawtooth appearance, which is called as the flutter waves, and QRS is narrow, so this ECG is suggestive of atrial flutter.
Okay. It's not very common in our perioperative period, but still. So usually the atrial rate is 250 to 300 and regular RR tachycardia. But you get a sawtooth flutter waves and the QRS is narrow. And the ventricular rate depends on the AV conduction ratio. And the management is?
Management is similar to that of the atrial fibrillation, except
Yes.
that the joules used are low, that is it is 50 to 100 joules.
Okay. Almost same management. Now just another ECG. You want to, which college are you from? I forgot. MES, you can try. This, what happened to the ECG rhythm after some time? It was normal initially, then what happened? You want
There is a
next,
paroxysmal supraventricular tachycardia.
explain the changes.
Initially, P wave is present
Yeah.
and rate is around more than 100. Later on, the rate is increased and P waves is not visible, or it is it is hidden.
Yeah. So, narrow QRS tachycardia. So, it could be
Supraventricular tachycardia.
paroxysmal supraventricular tachycardia. So, what could be the causes?
It could be due to any aberrant pre-excitation conditions or AV nodal reentrant tachycardias.
Here the QRS is narrow and P wave is usually absent or it is embedded within that. So you won't be able to see the P wave. You can see in this. In the initial part it is the normal ECG and then it is throwing the supraventricular tachycardia. So how do you manage?
Adenosine can initially vagal maneuvers like carotid massage, then pharmacological management such as adenosine 6 mg. If it is not reverted, then 12 mg. Then still not reverted, we can go for diltiazem or verapamil. If still not reverted, can go for cardioversion. Synchronized.
Okay. So how do you give adenosine? You said is correct. They look at whether it is stable or unstable patient. If it is stable patient, you can try vagal maneuvers by doing the carotid massage, and by the pharmacological you can give adenosine. How do you give adenosine?
It should be given rapidly.
Yes.
Usually,
Whenever you say adenosine, rapid IV. Okay. Followed by an IV
Saline
bolus, saline
push.
flush. Okay. It is initial bolus is 6
mg.
milligram, followed by
12 mg.
12 mg. Unstable, you go for cardioversion. What is this? Want to try?
This ECG shows ventricular tachycardia. There is wide QRS, and the rate is about 200, and there is tachycardia.
So it could be ventricular tachycardia. So how do you manage this?
Depending.
How is the QRS complexes? Is it of same morphology or not?
It is of same morphology. It can be treated medical management by amiodarone, and if not resolved, then cardioversion shock with the 200 joules.
When do you give shock in a
Depending upon the hemodynamic status of the patient.
Okay. Jisha, you can complete the answer. Jisha or Divya, whoever.
ECG findings in a ventricular tachycardia are the QRS complexes will be wide, regular, and of same morphology, and P waves will be absent.
Okay. So there are different types of ventricular tachycardia. What are they?
Depending on the duration of the ventricular tachycardia, it can be divided into sustained VT and non-sustained VT. In non-sustained VT, the duration will be less than 30 seconds. In sustained, it will be more than 30 seconds. Depending on the morphology of the QRS complex, the ventricular tachycardia can be classified into monomorphic VT and polymorphic VT. In polymorphic VT, the QRS complexes will be of a different morphology.
Okay. So it could be monomorphic or polymorphic VT, and as she said, the rate will be around 150 to 250. It will be regular, but P waves are not seen because the QRS is wide, and it is wide and broad in more than 120 milliseconds, and the T waves are also not identifiable. How do you manage?
If the patient is hemodynamically stable, amiodarone infusion 150 milligram over 10 minutes, followed by infusion of 1 milligram per minute for 6 hours, and then 0.5 milligram per minute for after that. If the patient is hemodynamically unstable, cardioversion with 100 joules has to be given. If the VT is of pulseless type, defibrillation is the treatment.
Okay. So pulseless VT is an indication for CPCR, defibrillation. Okay. That you have to, in an unstable VT, just it is unstable, go for cardioversion, otherwise defibrillation. In this juncture, I want to ask, what is the difference between cardioversion and defibrillation? Amala, what is the difference between cardioversion and defibrillation? This is usually asked in the exam in many various situations. If you get a MS case or anything, you will be usually asked this question. Anyone else want to try? Cardioversion was defibrillation? You may be knowing, but you may not be knowing how to express it. The mic is not on, I think.
In cardioversion, we synchronize it with the R wave and then apply the shock.
No, all the difference, not just single point. There are, you say, one is correct, it is synchronized to the R wave. What do you mean by this synchronization? How do you do that? Tisha, you want to try?
In stable patients, we do cardioversion, and in unstable patients, we do defibrillation. And also in cardioversion, we synchronize it with the R wave while we check the pulse, and we synchronize with the pulse.
How do you do that? Check the pulse and what about the energy level?
100 joules.
How much joules are used for defibrillation and how much for the cardioversion?
Joules used for cardioversion will be lesser and
Yes.
compared to joules used for defibrillation.
Yes. One is the synchronized to the R wave, that is in the machine itself you can press the synchronize button so that the delivery of the current will be synchronized to the R wave. Okay, that is how. And one is in a very unstable patient like cardiac arrest, that is where pulseless VT. What are the indications for defibrillation? Other teams, indication for defibrillation? What are the, which all rhythms you will do defibrillation? These are very basic question. Which all rhythm you will do defibrillation?
Ventricular tachycardia.
Pulseless VT,
Fibrillation.
Ventricular fibrillation.
ventricular fibrillation,
Unstable torsades dyspnea.
unstable torsade also you can do. So pulseless VT and VF, those are the two things, important things. Okay. So these are basic questions where you do defibrillation. So cardioversion with a smaller joules, it is synchronized, and it is usually an elective procedure. Defibrillation is an emergency procedure. Patient is going in a cardiac arrest. So it is an emergency. Cardioversion is an elective procedure, and you can sedate the patient, okay, because it's a painful procedure, a little pain. So you can sedate, and it's done in an elective manner. Okay, and smaller current is used. It is synchronized to the R wave. Okay, this is a basic question which you all should know. And again, Disha, or
This ECG shows wide irregular QRS complexes of different morphology. The QRS complexes are twisting around a central axis, and P waves are absent. These features are suggestive of torsades de pointis.
okay, it's almost similar to the previous ECG. You can see here all the QRS also are of similar morphology, and the baseline also same. But here you can see the varying morphology of the QRS complex, and the baseline is also changing. So it is polymorphic ventricular tachycardia or torsade de pointis. How do you how do you proceed then?
Here also management depends on the hemodynamic stability of the patient. If the patient is hemodynamically stable, injection magnesium of 2 grams slowly over 10 minutes can be given. If the patient is unstable, defibrillation is a treatment.
Okay. So QRS morphology is different. That is why it is called multiform or polymorphic ventricular tachycardia. Here it carries the risk of patient going in for ventricular fibrillation. So you have to manage, take it seriously. Any of you please. Ventricular fibrillation. So how do you manage? We just now we said. Yes. Start CPCR. What is this? I am very sorry that diagnosis is there. Suppose during the intraoperative period, you will see such an ECG in the monitor. What will you do? Surgery is undergoing, and you are watching, you are seeing this line in the ECG monitor. What will you do? Huh? Speak to the mouth.
Check
mic.
for disconnection
Check
if
the
any.
ECG leads if it's
Yes, check
properly
the
connected.
pulse and see whether the leads are disconnected or not. Okay. It could be asystole also, but before that, check the pulse, finger on pulse, and see whether the leads are disconnected or not. Most commonly, it could be a lead disconnection. So always your finger should be on the pulse. Suppose it is asystole. What do you do?
Initiate CPR.
Okay, initiate CPCR. So we'll see some ectopics, ECGs of ectopics. The middle team.
Ventricular ectopics.
So explain the morphology of the waves.
The ECG shows of ventricular ectopics. The QRS wave of the ectopic is wide. P wave is present, but it is P wave is absent.
For exam, always explain the ECG before you say the diagnosis. Okay, that will be better.
This ECG shows wide slurred QRS of uniform morphology without a preceding P wave. The QRS and T are in the opposite direction with a complete compensatory pose. So this ECG is suggestive of unifocal ventricular ectopics.
Okay, you can see the ectopic impulses are of the same morphology. And there is, so what do you mean by this compensatory pose?
We measure the RR interval between the ectopic and the succeeding QRS complex, and then we will measure the RR interval between the preceding QRS and the QRS after the ectopic.
Okay.
If the second value is double the first value, then we say there is a complete compensatory pose.
Okay. So the between the preceding and the succeeding R wave, you take the RR interval. If it is double the other normal RR interval, it is completely compensated. So here for the ectopic beat, there won't be any P wave, but the QRS complex is widened and slurred and of similar morphology it is coming in between, and it is associated with it is followed by a compensatory pause. And the QRS and T are in the opposite direction. You can see in this QRS and T are in the opposite for the ectopic beat. That is called unifocal ventricular ectopic. Here, just because the diagnosis is already written, I'm very sorry. So what is the difference from the previous one?
Different morphology for the QRS complex is there.
So here the ectopic beats are same morphology. Unlike that, here you can see the varying morphology of the ectopic beats. So it is a multifocal ventricular ectopics with compensatory pause again. So here the extrasystole arise from different foci. That is why the different morphology of the ectopic beats, and that which gives different QRS complexes. So when to treat such a ventricular ectopics? When will you treat an ectopic beat?
If the ectopic is more than 6 in number or multifocal in origin, and
more than 6 per minute.
Okay, and multifocal in origin, then if there is 3 successive ectopics are there, or when the R on T phenomenon, the ectopic falls on the T of the T wave, so that it will there's a chance to go for
Okay.
VT.
And another is R on T phenomenon. So this is 2 minutes, sorry.
This ECG shows a heart rate of around 50 beats per minute. Morphology of P, QRS and T are normal, and each P wave is followed by a normal QRS complex, and the PR interval is also normal. So this ECG suggests of sinus bradycardia.
So causes?
Sinus bradycardia can be seen as a normal variant and also seen in pathological conditions like myocardial infarction.
Okay, that you have to know since the time is running. So what is this ECG? I didn't see the time before, sorry. So I think I will ask my team to answer, otherwise it won't be able to complete. So?
Similar to previous, in this ECG, the heart rate is around 80 beats per minute. Morphology of P, QRS and T are normal. Each P wave is followed by a normal QRS, but the PR interval is prolonged. Normal PR interval is 0.1 to 2.2 seconds.
So here the waves morphology, everything is same, normal, except PR interval is prolonged. So what could be the diagnosis?
Type 1. First degree heart.
First degree heart block. So heart block could be first degree, second degree or a third degree or complete heart block. So you can read the ECG.
In this ECG, we can see that the heart rate is irregular. Each P wave is not followed by a QRS complex, and also there is a progressive prolongation of the PR interval until one QRS complex is lost. So this is suggestive of second degree AV block, Mobitz type 1.
Okay, so in second degree type 1 block, there is progressive prolongation with a missing beat. And this,
Similar to Mobitz type 1, this ECG is in this rhythm strip also. P wave is not, all P waves are not followed by a QRS complex. There is one missing QRS here, but the PR interval is fixed in all the leads.
okay. Can I take 2 more minutes or 2 more minutes? So this is,
This ECG shows a heart rate of 40 per minute, and the P wave and the QRS are independent of each other. Some P waves precede QRS, some after the QRS, and some were with QRS. So this ECG is suggestive, and the QRS is wide also. So this ECG is suggestive of complete heart block.
okay. So what is the treatment for complete heart block?
Pacing.
So same in a second degree heart block also, do you want to treat before preoperatively?
If the patient is symptomatic, we can transcutaneously pace the patient.
I mean, that is intraoperatively if it is showing. So preoperatively, if the patient has shows any symptoms, you have to go for pacing. Okay, pacemaker insertion. Same for the complete heart block also. So how the pacemaker ECG, the patient with the pacemaker.
This ECG shows sharp pacing spikes before P wave, and the QRS is of normal morphology. We can interpret both QRS and T waves. So this ECG with a normal PR interval. So this ECG is suggestive of atrial pacing.
Okay. So in the pacing, ECGs of a pacing will be either in a atrial pacing or a ventricular pacing. If the spacing spikes are before the P wave, it is the atrial pacing. If it is just before the QRS, it is ventricular pacing. If it's there both, it is both atria and ventricles are paced. This is ventricular pacing. How the bundle branch blocks?
In this ECG, we can see that in lead V1 there is an RSR pattern, and in lead V5, V6 and lead 1 there is wide slurred S wave. These features are suggestive of right bundle branch block.
So do you want to treat the right bundle branch block?
Right bundle branch block can be seen as a normal variant also, but in pathological conditions involving the right side of the heart, we have to treat the condition.
Okay. So if depending upon the cause. Okay. I just want to just one ECG. So just one more. This is the last ECG. Anyone want to try? You.
It is of right ventricular hypertrophy because the R wave is, there is a
Right ventricular hypertrophy. Anything else is there?
R wave in V1 with a strain pattern, T
Yes,
inversion
yes.
is there.
RVH with a strain pattern. So what do you do in a preoperative, pre-anesthetic checkup? Are you worried whether it is, if it is RVH alone or RVH with a strain? What is the significance of RVH with a strain, Jisha?
It means patient is going for failure.
Yeah,
we feel.
So underlying ischemic heart disease.
Underlying heart
So
disease.
patient can go in for failure. So that needs to be evaluated. So in ischemic heart disease also you have to be very, depending upon the what it is. Is this ST elevation or T inversion, and the leads also you should know which wall denotes the changes. Just explain this ECG also.
In this ECG, we can see ST elevation in leads V1 to V4, which are suggestive of anterior wall MI.
Okay.
ST elevation MI.
Okay, so for exam purpose, you should go in a systematic way, see the rhythm is regular, then calculate the rate, then see all waves are followed by the P are followed by QRS, and see the morphology, intervals, and any abnormal changes, and interpret after that only. Explain the wave first, then you interpret the diagnosis, and you should know the management depending upon the cause, possible cause you should remember. Okay. Thank you.